Assalamu alaikum. Good afternoon, everyone, and welcome back to our academic activity for today. So today we have first lecture will be about trauma to the great vessels by Dr. Ahmed Al-Amri. The second will be about pulmonary embolism by Dr. Fatma Al-Hijab, and the third one will be special presentation by Dr. Beka about pulmonary thromboanephrectomy. Then we'll end up by journal club of mechanical versus by prosthetic valves by Dr. Noura Gumi and Dr. Firas Fatani. So I believe we'll start 5 minutes past 1. Dr. Ahmed, you can prepare your presentation. Thank you. Dr. Ahmed.
Assalamu alaikum.
Assalamu alaikum. You can start.
I hope everybody can hear me and see my slides. You can see my slides?
Yes, go ahead.
Yes. Good afternoon, everybody. Today's presentation is going to be about great vessel trauma. The outlines for this presentation is going to be focused on the blunt thoracic aortic injury, about epidemiology, clinical presentation, classification, and evaluation of patients with blunt aortic injury, and finally, management. So, patients involved in high energy blunt aortic trauma that involve rapid deceleration are at higher risk of blunt aortic injury. And this is the main mechanism behind blunt aortic injury, rapid deceleration. And it's the second most common cause of death behind head injury in trauma fatality. As you know, that head injury is the leading cause of death after trauma. Just behind that is the blunt aortic injury. And it has been suggested that only 20% of the patient with blunt aortic injury survive long enough following the injury to be treated. So from that, we take that around 80% of the patients with blunt aortic injury do not make it to the hospital to be treated, and usually dies either on the scene from hemorrhage or on the way to the hospital, which give you an idea how life-threatening is the condition. Around 7,500 to 8,000 victims die of blunt aortic injury every year in the United States. And from recent review, around 20,000 victims of blunt aortic injury in the United States every year. 8,000 of them dies either on the way or on the scene or in the hospital. So the mortality rate is high for blunt aortic injury. 1 in every 6 people killed in a vehicle accident sustain this type of injury. And the majority of them are due to motor vehicle accidents. It's not the only cause, but the majority of them from high-speed motor vehicle accident. Other causes include crash injury or fall injury as well. So the mechanism of blunt traumatic aortic injury. In this diagram, you can multiple theory behind the blunt aortic injury. In the first diagram, you can see that the ascending aorta is in close proximity to a bony structure, which is the sternum. And the descending aorta is in close proximity to the vertebral column or the thoracic vertebral column. And those bony structure during trauma can work as an osseous pinch and can injure the great vessel. This is one mechanism behind the blunt aortic injury. Because of the relative fixation of the aortic isthmus, which is the part of the aorta, of the descending aorta, just distal to the left subclavian artery, that is fixed by the ligamentum arteriosum. This part is relatively fixed of the aorta, while the other parts of the aorta are relatively mobile. Around this area, with the rapid deceleration what can happen that torsion of the aorta around itself because of fixation above and mobility below. It can be also explained by water hammer effect. The water hammer effect is because of distal compression or distal vasoconstriction of the aorta during trauma that can cause abrupt and severe increase in the blood pressure that translate into aortic injury by injuring the layers of the aorta. Other theory can be because of stretching of the aorta during the rapid deceleration or the fall injury. Can be also because of shearing of the aorta. So we have multiple theory or mechanism of blunt traumatic aortic injury. There are clues that can give you a high suspicion toward an aortic injury. It can be taken from the patient himself, from the EMS upon arrival to the hospital, or from physical sign you can see. And from the history, if the patient sustained motor vehicle crash that is more than 50 km per hour, high-speed motor vehicle crash, or a motor vehicle crash into a fixed object or fixed barrier, or if the victim was not wearing a seat belt, or if there is a history of ejection from the vehicle, if you found a broken steering wheel, or a motorcycle or airplane crash, or a pedestrian hit, if there is a fall that is more than greater than 3 meter, or a crash injury, or if the patient loss of consciousness. All of these clues can raise your suspicion toward an aortic disruption in the history. Physical sign that you can see: hemodynamic shock from hemorrhagic shock, or a fracture of the bony structure around the aorta, especially the sternum, the ribs, clavicle, scapula, or the vertebra. If there is an imprintation of the steering wheel on the chest of the patient, or a seatbelt sign, cardiac murmur, which is important because there is an association usually between the cardiac injury and the great vessel injury. Hoarseness can happen because of nerve compression by the hematoma or the pseudoaneurysm. Dyspnea, back pain, hemothorax. As you know that the descending aorta is in close proximity to the left thorax. Any bleeding or extravasation of the blood will be collected into the left thorax, will be explained by a left hemothorax. Like in aortic dissection, you can find an unequal extremity blood pressure, either between the both upper limbs or the upper and lower limbs. Paraplegia or paraparesis can be because of distal hypoperfusion, distal to the injury. So your initial evaluation of patient with suspected aortic injury you should have a high index of suspicion. You should follow your ATLS protocol, starting with primary survey. Use your adjuncts to primary survey, chest X-ray, history, ample history, including the mechanism of injury, and the secondary survey with their adjuncts like the scans or radiography. If the patient become hemodynamically unstable at any point during your ATLS assessment, you should, and with signs of hemorrhage, you should go directly to the OR for bleeding control. So your typical patient with presentation in the history from the mechanism of injury, if there is an injury suggesting a rapid deceleration, or symptoms like dyspnea, back or chest pain, from physical exam, shock, different blood pressure readings, ecchymosis over the chest, or a seatbelt sign. From a subclavian injury, you can find a subclavicular bruit or swelling, or even Horner syndrome from compression to the nerve. So how do we classify traumatic aortic injury? There is many classification system over the years, but the most approved one, and the one from the Society of Vascular Surgery, is depending on the layers of the aorta. And this classification system classifies the injury to the aorta into 4 grades. Grade 1 include only the innermost layer of the aorta, which is the intima, which include only intimal tear or an intimal flap without any hematoma. In grade 1, in other classification, they call it minimal aortic injury as well. Grade 2, when you have an intramural hematoma that does not exceed 50% of the circumference of the aorta. If it exceeds 50% of the circumference of the aorta, it's called a pseudoaneurysm or grade 3 aortic injury. The most severe form is grade 4, when you have an extravasation of the blood, or rupture or transection of the aorta. So your diagnostic evaluation should start with chest X-ray, and chest X-ray is very helpful in aortic injury. It can help you rule in aortic injury, but does not help you rule out an aortic injury. There is actually 15 findings in the chest X-ray that can be associated with an aortic disruption. The first one, and the most known one, is the widened mediastinum. And widened mediastinum in supine chest X-ray, that is more than 8 centimeter, or in AP view more than 6 centimeter, considered significant. If the mediastinum to chest width ratio more than 25%, or if there is a tracheal shift to the patient right from hematoma or pseudoaneurysm, blurred aortic contour, or an irregularity or loss of aortic knob, left apical cap, or a depression of the left main bronchus, ossification of the aortopulmonary window, or if there is a nasogastric tube, you will find right deviation of the nasogastric tube, wide paraspinal lines, fracture of the ribs or the clavicle, pulmonary contusion, or a thoracic spine fracture. All of these 15 findings can be associated with aortic injury. After the chest X-ray, you should do, all trauma patients will undergo trauma band CT, but you should add an CT scan with IV contrast of the chest, and CT scan, CT angiography can help you diagnose and classify aortic injury because it has high sensitivity and high specificity toward an aortic injury. You can see in the first picture demonstrating a grade 1 intimal tear in the descending aorta, grade 2 that is less than 50% of the total aortic circumference, grade 3 more than 50%, and grade 4 rupture or complete transection. Here is some example from CT scans. The first picture is a helpful picture in understanding the mechanism behind the blunt aortic injury. There is two levels of injury in this picture. The first, or proximal injury, most likely is related to stretching mechanism, and the second, or the distal injury, is associated with vertebral fracture at the same level, which can explain this type of injury. So it's most likely between grade 2 to grade 4, grade 2 to grade 3, sorry, aortic injury. This is a picture of grade 3 aortic injury. You can see that in the black arrow pointing toward the pseudoaneurysm, that is more than 50% of the circumference of the aorta. Here you can see two levels of injury. In the ascending aorta, there is a peri-aortic hematoma, and in the descending aorta, there is extravasation of the blood into the left thorax with left hemothorax. Another picture showing the comparison between chest X-ray and CT scan in cases of grade 4 aortic injury with left hemothorax. CT scan can also give you a false positive CT angiography. There is two main variants that can mimic an aortic injury. You should know about it. The first one is called the aortic spindle. Aortic spindle is an anatomical variant that is most of the time benign. It's a fusiform dilatation of the isthmus, which is the most common site of injury. The difference between this anatomical variant and the aortic injury is the absence of intimal tear and the smooth dilatation, the fusiform dilatation of the aorta. Another false positive CT angiography is the aortic ductus diverticulum, and this is a remnant of the ductus arteriosus in the isthmus of the aorta. Again, you will not have any intimate tear, and there is a smooth dilatation around this area. Most of the time, CT scan is sufficient to diagnose and classify aortic injury. But in the old days, the gold standard was aortography. Nowadays, it is reserved to vascular intervention. When you plan for vascular intervention, you can do an aortography. But in some situation, you might need it. You can see in the first picture, the black arrows pointing toward the pseudoaneurysm, and here after the endovascular IVUS, intravascular ultrasound, also an invasive tool that is reserved to intravascular intervention. It is helpful in diagnosing and determining the limitation of the injury, the level of injury, and the amenability for TEVAR, for example. Transesophageal echo. Usually, transesophageal echo is not routinely done in all patients, but in some situations, if the patient is hemodynamically unstable and you push the patient to the OR, the anesthesiologist should do a transesophageal echo if you don't have a CT scan before that. And transesophageal echo can help you in identifying the level of injury, the flaps, and as well as the pseudoaneurysm and the intramural hematoma. So management. The management of blunt aortic injury, it's according to the grades. So grade 1, which is minimal aortic injury, most of the time the patient does not require any surgical or endovascular intervention, and they usually only need a medical therapy with serial imaging and follow-up. Grade 2, those patients will need endovascular intervention by TEVAR or an open surgical repair. Grade 3, TEVAR or open surgical repair. Grade 4, those patients will need an emergent TEVAR or emergent open surgical repair. We'll start with medical management. It should start with strict blood pressure monitoring for your patient, and to keep the systolic blood pressure less than 120 and the MAB less than 80, and control the heart rate as well. And this is because you need to decrease the wall stress on the aorta, and most of the time we are using short-acting beta blocker for this. There is many talks about liberal resuscitation in trauma and restrictive resuscitation in trauma. In this situation, aortic injury, you want to decrease volume, especially in more minimal injury, grade 1, grade 2, to not progress toward pseudoaneurysm and rupture. So it's many literature review, articles review, suggest a restrictive resuscitation strategy in those type of patients. We'll start with the open surgical repair. The first successful open operative repair for blunt aortic injury was done in 1953 by Dr. DeBakey and Dr. Cooley. It was called the clamp and saw technique, or the clamp and saw repair. What they used to do, they will do a posterolateral thoracotomy. They will retract the lung and expose the aorta, the descending aorta. They will clamp before and after the injury, and then replace the affected part by interposition graft. What they have noticed at that time, the high rate of paraplegia associated with this technique, because during the clamp there was no distal perfusion. The modification for this technique, they used to do a shunt between the ascending aorta and the distal part of the descending aorta, or the distal part of the clamp, and this helped in decreasing the rate of paraplegia during their clamp and saw technique. But with the advances of cardiopulmonary bypass and the bypass machine, repair now are done under either left heart bypass through pulmonary vein to femoral artery bypass, or a complete cardiopulmonary bypass from femoral bypass. And this, by the modification to this technique, they decrease the rate of paraplegia significantly. About the paraplegia that was associated with the surgical management, this is a meta-analysis that was published in late 90s, comparing each technique in terms of paraplegia. So the first technique that was invented by Dr. DeBakey and Dr. Khoury, without any distal perfusion, was associated with around 19.2% of paraplegia. When they added the passive shunt, they decreased the rate of paraplegia to 11.1. The cardiopulmonary bypass decreased up to 2.4. And the partial bypass, which is the left heart bypass, decreased up to 1.4%. So the best technique now for open surgical repair is left heart bypass with repair of the affected parts with Dacron or interposition grafts. After in the endovascular repair era, nowadays most of the patients will go into TEVAR, and TEVAR have replaced the open surgical repair for many aortic pathology, especially in descending aorta. And this is how it's done, usually through either percutaneous or open femoral axis. They will introduce their wires and stent, and then deploy the stent in the affected area. They have found difficulty in landing point or landing zone for aortic injury because of the close proximation to the left subclavian artery. And they suggest either selective revascularization of the left subclavian, or in some situation you might need to do left subclavian to carotid bypass, or carotid to left subclavian bypass. Here is the stent in place by 3D CT, and this is the follow-up. About timing of repair, when should we repair the vascular or the aortic injury? Should we do it in the first 24 hours or after 24 hours? Here is a paper that was published last month, March 2021, about the timing of repair of blunt thoracic aortic injury in the endovascular repair era. They included 2,821 patients. It was a retrospective review. They found that TEVAR within the first 24 hours of aortic injury carries a mortality rate of 9.8%. While TEVAR, if it was delayed after 24 hours, the mortality will decrease up to 4.4%. And it was significant p-value. So from this, we take that delayed intervention is preferred if the patient is hemodynamically stable. What about the guidelines? The guidelines for aortic injury, the last one was around in 2012 by the Society of Vascular Surgery. There is no good or strong recommendation. All are class 2, and the quality of evidence always low or very low. Okay, choice of treatment. They suggest endovascular repair over the open or non-surgical technique. The timing for repair, they suggested urgent at least prior to hospital discharge. And the management of minimal aortic injury grade 1, they suggest expectant management with serial imaging. Usually it is done 6 weeks after the patient discharge to follow up the progression of the aortic injury. For the type of repair in young patients, they also suggest endovascular repair regardless of age. For management of left subclavian artery, they suggest selective revascularization. In heparinization, they suggest lower dose of heparin than the usual TEVAR or the elective TEVAR. No need for spinal drainage, and general anesthesia is preferred for an urgent or emergent situation. And the access, they suggest open femoral access for urgent or emergent TEVAR. Okay, this is a review article about blunt aortic injury. In comparing the three techniques, the endovascular repair, the bypass or the shunt repair, or the clamp and sew technique, in terms of complication or some clinical scenarios. In operative stress, as expected, it's the highest in surgical, especially the one without bypass. Blood loss is higher in the surgical group. Operative time is higher in the surgical group, especially the one with bypass. Paraplegia is the lowest in endovascular repair. If the patient high surgical risk or severe lung injury or have severe head injury, it's preferred to go for endovascular repair unless there is a challenging anatomy or it's not amenable for TEVAR. Then you go for a shunt or bypass repair. In the next few slides, I will speak about management according to location of the aortic injury. We'll start with the ascending aorta. Ascending aorta is treated as an aortic dissection. It's always open surgical repair. There is no endovascular technique well established for ascending aorta injury. You will always go with median sternotomy. It's preferred to go for cardiopulmonary bypass preferably before you open the chest to decompress the pseudoaneurysm and to not injure the aorta or rupture the aorta during your median sternotomy. You should do proximal and distal mobilization of the pseudoaneurysm and control proximally and distally. If you found difficulty in controlling proximal and distal part of the pseudoaneurysm, then you might need to go under deep hypothermic circulatory arrest. Even with other indication is when you have a proximal arch involvement. And then you replace your affected part with usually interposition graft, and then you carry on. You would do you assess your valve as well if there is need for an further intervention. Aortic arch branch vessel injury. We'll start with the first one, which is the innominate artery. And the innominate artery, there is multiple levels. I will only speak here about the proximal branch aortic arch branch vessel injury. So if there is a proximal innominate artery injury, then bypass is the best option for this patient. You can do through medial sternotomy and right neck extension to expose the innominate artery. What you will do, you will clamp proximal to the injury and distal. Then you will use a prosthetic graft or a vein graft to bypass this from the ascending aorta into the distal healthy part of the innominate artery. In many situations, or the majority of the patient, you will not need bypass, or in healthy individual, the collaterals from the left carotid vertebral artery is sufficient during your short clamp time. But in patients with severe left carotid or carotid calcification disease, you might not tolerate the clamp time for this period. So you might need to do cerebral protection strategies and might go under also hypothermic circulatory arrest and bypass. But in most situations, you will not need for short clamp time for the anastomosis. Carotid artery injury, proximal or carotid artery injury. The same technique, median sternotomy with left neck extension to expose the carotid artery. There is many level of carotid artery injury. I'm only speaking about the proximal part and different management for the other level. So proximal carotid is treated by bypass from the ascending aorta toward the distal healthy part, similar manner to the previous one. Left subclavian artery. Left subclavian artery. It's difficult to control the bleeding from left subclavian artery because of the presence of the clavicle. You cannot compress the vessel. So for patient who is bleeding from a left subclavian injury, you might go through a high thoracotomy with a clamp proximal to the injury to provide control of the bleeding until you shift the patient to the OR. For treatment or repairing the subclavian artery, there is many technique, either through a supraclavicular incision, infraclavicular incision. In some situation, you might need to remove the clavicular bone to expose the vessel, but usually the repair of subclavian done by direct repair by suturing the vessel, the bleeding part, or batch repair. I finished this part of the presentation. This is the references. And thank you for listening. If you have any questions or comments, please.
Thank you, Ahmed. I like the pictures. Thank you so much.
Any question for Ahmed? Okay, we'll have a break for 10 minutes. We'll come back. So we'll start 1:50 sharp. دكتورة فاطمة.
Yes, doctor.
Yes, Fatima, you can start.
Okay. Hello, everyone. Today I'm going to talk about pulmonary embolism. So I have a problem with my slides. Now it's moving. So the general outline for my presentation today are present in here. I would start with the epidemiology. So as you know that globally, venous thromboembolism is considered the third most frequent acute cardiovascular syndrome behind myocardial infarction and stroke. Pulmonary embolism nearly causes 300,000 deaths per year in the US, ranking high among the causes of cardiovascular mortality. So there are several predisposing factors to the formation of the thrombus and leading to pulmonary embolism. They are being stratified into three categories: strong, moderate, and weak risk factors, depending on the odds ratio value. So starting with the strong risk factors, those are including the fracture of lower limb, hospitalization for heart failure or myocardial infarction within the previous 3 months, hip or knee replacement, previous history, VTE, and spinal cord injury. For the moderate risk factors, they are considered to be the most variety of risk factors, and the most important ones are the chemotherapy, congestive heart failure or respiratory failure, the use of oral contraceptive or hormonal therapies, being in postpartum period, cancer, and superficial vein thrombosis. For the last predisposing risk factors, which are considered to be weak ones, the first one is the bed rest for more than 3 days and for sure for less than 1 week. Other comorbidities being involved in other disease can also be considered as a weak risk factors, like the DM, the arterial hypertension. Also, a history of obesity and pregnancy or varicose veins could be included in the weak risk factors. So for the development of pulmonary embolism, we have to know that an acute PE interferes with both circulation and gas exchange. So the primary cause of death in severe PE is considered to be the right ventricular failure due to acute pressure overload. So after getting to know the Virchow's triad, which involves the three underlying causes or mechanisms of developing a thrombus, we can summarize them in hypercoagulopathy, venous stasis, and venous injury or endothelial injury. So to start with the pathogenesis, we have to know that the recent plug thrombus are more likely to migrate, and the chronically formed thrombus are more attached to the site of origin. So they are usually formed at the venous saccule or the venous valve pocket, and they're less prone to be migrated through the circulation. However, an acutely formed thrombi might detach and migrate and travel through the bloodstream, reaching the right side of the heart and then to the pulmonary circulation. The majority of pulmonary emboli lodge in the lower lobes and more commonly in the right lung because they are more like relatively flow in that side. The lungs emboli become coated with a layer of platelets and fibrin. And in addition to that, more factors being involved, humoral factors. Most importantly, the serotonin, the adenosine diphosphate, platelet-derived growth factor, and thromboxane A2. So anoxia would result and tissue ischemia, inhibit the production of the endothelial-derived relaxing factor production, and it would also increase and enhance the release of superoxide anions. Those two factors, like preventing or inhibiting the endothelial-derived relaxing factors, would increase the pulmonary vasoconstriction. And also with the presence of a mechanical obstruction of the thrombus and increasing the pulmonary vasoconstriction, those two factors or underlying mechanisms would also result in increasing in the pulmonary vascular resistance. Increasing in the pulmonary vascular resistance would lead to RV dilation. The RV dilation would definitely interfere and affect the contractile properties of the right ventricle, as we know from the Frank-Starling mechanism and law. So increase in the RV pressure and volume would lead to increase in wall tension and myositis stretch. And also, as a result, the contraction time of the RV is going to be prolonged. A neurohumoral activation would happen, increasing the inotropic and chronotropic effects. So after all of this, there would be an increase in the pulmonary arterial pressure and even the flow with this increased pulmonary arterial pressure that happened after a blockage of approximately 30 to 50% of the arterial pulmonary pulmonary arteries. The flow through the obstructed pulmonary vascular bed would be increased. So the prolongation of the RV contraction time into the early diastole in the left ventricle would result in like a leftward flowing to the of the interventricular septum toward the left side. This would create such a desynchronization of the two ventricles. That also might be exacerbated by right bundle branch block. So the LV filling is embedded in early diastole, and this may lead to reduction in the cardiac output, compromising the hemodynamic stability and contributing to systemic hypertension. So here that leads us to the second mechanism, which is the respiratory failure after the RV. So it happens as a consequence of hemodynamic disturbance. So when we have a reduced RV filling, by default, the would have a low cardiac output, resulting in desaturation and low oxygen supply, and also desaturation of the mixed venous blood. So by then we would have two zones inside the lung: a zone of reduced flow in the obstructed pulmonary arteries, and a zone of overflow in the capillary bed. And this would end in ventilation perfusion mismatch, leading to hypoxemia. Also would have, due to the inverted pressure gradient, a right-left shunt through a patent foramen ovale. And sometimes with some patient that present with hemoptysis or pleuritis, the underlying pathophysiologic mechanism is that the small distal impli may create areas of alveolar hemorrhage. So this just diagram can summarize for us what's going on after like having a mechanical obstruction in the pulmonary arteries. This would increase the right ventricular afterload, leading to RV dilatation, having like a TV insufficiency functional. And after having the TV insufficiency following with a neurohumoral activation and myocardial and temporary inflammatory process, RvO2 demand would increase. So as a result, we would have the contractility of the RV after the dilation is going to be decreased, affecting the cardiac output and affecting the amount of oxygen being supplied to the coronaries as well as the systemic circulation. So in other patients with sufficient cardiopulmonary reserve and right ventricular strength, autolysis of ampli occurs over the next few days and weeks. Natural fibrinolytic system dissolves the ampullary mass, and that would result in pulmonary vascular resistance and increasing the arterial compliance inside the lung. However, surgical empulectomy is not necessary for survival except in a minority of patients. So for patients with pulmonary embolism, according to the new guidelines, that the risk assessment and being involved for such patients. To do a risk assessment for patients, we have two rules. The first rule is the revised Geneva clinical prediction for pulmonary embolism and the Wells clinical prediction. So basically, the items being involved in the two rules are somewhat similar. They're including the previous history of BE or DVT, surgery or fracture, unilateral lower limb pain, and also the presence of active cancer or malignancy and hemoptysis. So for the Geneva clinical prediction rule, there are like two rules. Previously, there was an original version, and now there is a simplified version. For both of them, the rules, the revised Geneva and the Wells, after scoring the patient can be in one of three levels or three categories, either a patient with low probability of having PE, intermediate, or high. And sometimes we can divide those patients after scoring them into two-level score, whether they fall in the PE unlikely patients and the PE more likely diagnosis. So regardless of the score used, the proportion of patients with confirmed BE can be expected to be 10% in the low probability category, 30 in the moderate, and 65 in the high probability category. When the two-level classification is used, a patient which is confirmed to have a BE has a percentage of 12% to be in the BE unlikely category and 30% in the BE likely category. So here is another criteria, which is the pulmonary embolism rule-out criteria. This criteria have been developed for patients in the emergency and who have a low probability of having a pulmonary embolism, and we don't want to make them go through the lung diagnostic workup to discover whether they have BE or not. So they comprise 8 clinical variables significantly associated with an absence of pulmonary embolism. Those are including age being less than 50 years, pulse less than 100 beats per minute, oxygen saturation of 94%, no unilateral leg swelling, no hemoptysis or recent trauma or surgery, neither history of VTE or oral hormone use. So for recently, there are some other studies that do not support or go against the generalizability of this exclusion criteria. So for pulmonary embolism, there are specific guidelines that were published in 2014 and then in 2019. In comparison to those two, I would like to talk about the new points in the guidelines of 2019. So regarding the diagnosis, the D-dimer cutoff values has been adjusted in 2019 according to age, and another D-dimer cutoff values has been adjusted also to clinical probability. Also, there was an update information was provided on the radiation dosage when using the CT, pulmonary angio, and lung scan. Regarding the risk assessment, the new points were a clearer definition of hemodynamic instability patients and those who are at high risk of developing BE. Also, there was a clear assessment of BE severity and early BE-related risk, in addition to overall assessment for death. Also, there was a clear word of caution that RV dysfunction may be present and affect early outcomes in patients at low risk based on clinical risk scores. Okay, so regarding also the treatment in the acute phase, and also we have the chronic phase, the new points or the added to the 2019 guidelines where a dedicated management algorithm is proposed for high-risk pulmonary embolism. NOACs are recommended as the first choice and vitamin K antagonist as an alternative. The risk-adjusted management algorithm was revised to take into consideration clinical pulmonary embolism severity, comorbidity, and the presence of RV dysfunction. For the chronic treatment after the first 3 months, risk factors for venous thromboembolism recurrence have been classified according to high, intermediate, and low recurrence risk. Potential indications for extended anticoagulation are discussed, including the identifiable risk factors for having a recurrent attacks of pulmonary embolism. Terminologies that have been used previously, such as provoked versus unprovoked pulmonary embolism or VTE, is no longer supported in the new guidelines. VTE recurrence scores are presented and discussed in parallel with bleeding scores for patients on anticoagulation treatment. Reduced dose of apixaban or rivaroxaban for extended anticoagulation should be considered after the first 6 months of treatment. And lastly, the long-term sequelae, an integrated model of patient care after pulmonary embolism is proposed to ensure optimal transition from hospital to community care. And the recommendations on patient care have been extended to the entire spectrum of post-pulmonary embolism symptoms and functional limitation, not only on the chronic pulmonary hypertension, thromboembolic pulmonary hypertension. A new comprehensive algorithm is also proposed for patient follow-up and how to monitor those patients after having the acute pulmonary embolism. So if you can just look at this diagram that can summarize the changes in here. So first of all, in 2014, it was the rescue thrombolytic therapy is recommended for patients who deteriorate hemodynamically. It was a class 2A indication in 2014. However, in 2019, it has become the class 1 indication. And if you can just take a look at the last point, further evaluation may be considered for symptomatic pulmonary embolism survivors at an increased risk for CTEPH was class 3 indication in 2014. However, in 2019, it is now class 2B. So we have to do a further evaluation. Okay, so I would start with the guidelines regarding the diagnosis. So we have patients with who are suspected to have pulmonary embolism with hemodynamic instability, and others are hemodynamically stable. So with hemodynamic instability and suspected high-risk pulmonary embolism, as indicated by the presence of hemodynamic instability, bedside echo and CT pulmonary angio is recommended for diagnosis. This is a class 1 indication. It's also recommended to start on IV anticoagulation with unfractionated heparin, also as a class 1 indication. For suspected pulmonary embolism patient without hemodynamic instability, also you have to use a validated criteria for diagnosing pulmonary embolism, and also it is class 1 indication to start an anticoagulation even when the diagnostic workup is in progress. Okay, so here we reach to the D dimer. As I've told you that we have an editing upon the D dimer use. So it's a class 1 indication to use the plasma D dimer and in outpatient and emergency department with low or intermediate clinical probability to have a PE. Also, the D dimer measurement is not recommended in patients with high clinical probability, as a normal result does not safely exclude PE, even when using a highly sensitive assays. Okay, so the D dimer cutoff levels adapted to clinical probability and the age. So the clinical probability would depend on the size of DVT, the hemoptysis, and whether alternative diagnosis is less likely. So generally, we can summarize this diagram according to this model that the pulmonary embolism is excluded in patients without clinical items, which are the signs of DVT, hemoptysis, and considering other alternative diagnosis less likely, and D dimers level less than 1,000 milligram per liter, or in patients with one or more clinical items and D dimer levels less than 500. Okay, so another diagnostic test is to do the CT pulmonary angiogram, which is considered as the gold standard. So the prospective investigation on pulmonary embolism diagnosis study observed a sensitivity of 83% and specificity of 96% for the CT pulmonary angio and pulmonary embolism diagnosis. So considering a further test in case of discordance between clinical judgment and the CT pulmonary angio result can also be taken. So for the CT pulmonary angio, it's a class 1 indication to recommend to reject the diagnosis of PE without any further testing if it's turned to be negative. Also, it is recommended to accept the diagnosis of PE without further testing if the CT pulmonary angio shows a segmental or more proximal filling defect in a patient with intermediate or high clinical probability. CT venography is not recommended as an adjunct CT pulmonary angio. This is a class 3 indication. For the lung scintigraphy, we can use different materials like the xenon, the krypton, the technetium. So for the benefit for this lung scintigraphy is that being a lower radiation and contrast medium sparing procedure. So it can be used in several patients with different benefits, like in young, particularly the female patients and pregnant women, and in patients with history of contrast medium allergies or anaphylaxis, and patients with severe renal failure. So it's a class 1, again, indication to reject the diagnosis of pulmonary embolism without further testing if the perfusion lung scan is normal. Another diagnostic test is doing echocardiography, which is usually done at the bedside in the emergencies. A right heart dilatation raises the possibility of PE, and a negative result cannot exclude the pulmonary embolism. So we have different findings that can be elicited on the echocardiography. Mainly these include a right ventricular and IVC dilatation, and also it can include tricuspid valve insufficiency, a presence of thrombus in the right side of the heart, and also flattening of the interventricular septum. The compression ultrasonography. Majority of cases, PE originates from DVT in the lower limb and only rarely from the upper limb. The CUS has a sensitivity of not more than 90% and specificity of 95% for symptomatic DVT. Incomplete compressibility of the vein, which indicates the presence of clot, whereas flow measurements are unreliable. We have also duplex scanning and the MRA. So in the hands of skilled examiners, duplex scanning, which is a combination of ultrasound and color flow Doppler mapping, is highly accurate for the detection of thrombus. MRA is a non-invasive method that can image the entire venous system, including the upper extremity veins and the mediastinum. So for using the VQ scan, it might be considered for pulmonary embolism diagnosis. For the CUS, it is recommended to accept the diagnosis of VTE if the CUS shows a proximal DVT in patients with clinical suspicion of pulmonary embolism. This is a class 1 indication. And for the MRI, it is not previously it was not recommended for ruling out pulmonary embolism. However, this is a class 3 indication for now. Assessment of pulmonary embolism severity and the risk of early death was one of the new points that has been added to the 2019 guidelines. So the initial risk stratification is based on clinical symptoms and signs of hemodynamic instability. A further or advanced risk stratification requires the assessment of 2 sets of prognostic criteria: clinical, imaging, and laboratory indicators of pulmonary embolism severity, mostly related to the presence of RV dysfunction, the presence of comorbidity, and any other aggravating conditions that may adversely affect early prognosis. Imaging of right ventricular size and function. As previously, we have the echocardiographic barometers, which are being used to stratify the early risk of patients with pulmonary embolism. So one of those parameters is the RV to LV diameter ratio of more than one or more, and a tricuspid annular plane less than 16 millimeter also would suggest unfavorable diagnosis. We have also the computed tomography parameters. Here is a study that has been a meta-analysis of 49 studies investigating more than 13,000 patients with pulmonary embolism, confirmed that an increase in RV to LV ratio of 1 or more on CT was associated with a 2.5-fold increased risk for all-cause mortality. Apart from RV size and the RV to LV ratio, CT may provide further prognostic information based on the volumetric analysis of the heart chambers. Also, we can depend on the laboratory biomarkers like the markers of myocardial injury, including the plasma troponin elevated levels, which also would predict a worse prognosis, and also the heart type fatty acid binding protein, which also marker of myocardial injury. This is also provided a poor prognosis for patients with pulmonary embolism. Other markers of right ventricular dysfunction, like the PNP and NT-proPNP, we have also a bad prognosis when the NT-proPNP is more than 600, the heart type fatty acid binding protein of more than 6, and the copeptine of more than 24. So these markers have been validated previously in cohort studies, but they have not been used to guide the treatment decisions in randomized controlled trials yet. Okay, so we head to the scores for assessment of pulmonary embolism severity. So also in here, we have an original version and simplified version. The difference is only in including the sex for the or the male gender in the original version, and also for the respiratory rate, temperature, and altered mental status. Those have been excluded from the simplified version. So after scoring the patients according to the items present, which include age, the gender, the malignancies or cancers, chronic heart failure, chronic pulmonary disease, and mostly vital signs and mental status, and the arterial oxygen saturation. We can have our score in one of the 4 categories regarding the original version, and one from 2 categories for the simplified. So, and the original patient is lying in one of 5 classes. Class 1 is very low 30-day mortality risk. Class 2 is low mortality risk. Class 3 is moderate. Class 4 is high mortality risk. Class 5 is very high mortality risk. And after having the score of a simplified version, patient of pulmonary embolism will either have a score of 0 points or 1 or more. For a 0 score point, the patient has a risk of 30-day mortality of 1%. For patients who scored of 1 point or more, they have a risk of having a mortality within 30 days of with a percentage of 10.9%. So again, for evaluating the early mortality risk, for each patient that have hemodynamic instability, he is at high risk of having early mortality risk. For patients who are hemodynamically stable, but unfortunately they fall within the classification of 3 to 5, or within the second category on the simplified severity indicators assessment, and also they have RV dysfunction and elevated cardiac troponin levels. They are considered to have an intermediate high early mortality risk of in hospital or 30-day death. For patients who only have a clinical parameters of pulmonary embolism severity and either RV dysfunction or elevated cardiac troponin levels, they are considered to have intermediate low early mortality risk. For patients who only have elevated cardiac troponin levels, they are considered to have a low early mortality risk and to have death in hospital for in a duration of 30 days. So the recommendations for prognostic assessment and to have those rules, it's a class 1 indication to have the initial risk stratification suspected or confirmed BE based on the presence of hemodynamic instability. It's recommended to identify patients at high risk of early mortality. Also, it's considered a class 1 indication in patients without hemodynamic instability, and to do the further stratification of patients with acute pulmonary embolism into intermediate and low risk categories. Okay, so regarding the treatment in the acute phase, patient with pulmonary embolism, first priority is to maintain the hemodynamic and the respiratory support. And then to have a pharmacological treatment, treating the acute right ventricular failure if present, and having continuous monitoring of the CVP, and also using the vasopressor to support the right heart side failure if present. Also, in some patients, we might use the mechanical circulatory support. Initial anticoagulation is mandatory. Having a parenteral anticoagulation, low molecular weight, and fondaparinux are preferred over the unfractionated heparin. Vitamin K antagonists might also be used. In patients who are hemodynamically unstable and went through the cardiac arrest, thrombolytic therapy are being recommended, and CPR as well. So the reperfusion treatment, we basically depend on the systemic thrombolysis. The greatest benefit for those patients if they receive the thrombolytics within 48 hours, but it could be also used through a duration of 6 to 14 days. If you want to check whether the thrombolysis treatment has been successfully done, we have to check for the hemodynamic stability and the RV RV function on the echo after 36 hours. So just a few examples about the thrombolytics that are being used. We have the recombinant tissue plasminogen activators, streptokinase and urokinase. And also you have to monitor whether there is a contraindication to use these fibrinolysis. So for the absolute contraindication to use them is having a history of stroke or ischemic stroke in the previous 6 months, having a CNS neoplasm, major trauma, bleeding, diathesis, or active bleeding. For the relative contraindications of using the fibrinolysis is the transient ischemic attack, using oral anticoagulation, pregnancy, traumatic resuscitation, refractory hypertension with systolic blood pressure of more than 180, advanced liver disease, infective endocarditis, and active peptic ulcer. Also, as a treatment, we can consider the percutaneous catheter-directed treatment, and as a last stage, the surgical embolectomy. When we are comparing between the surgical embolectomy and thrombolysis, there is no difference in 30-day mortality, but thrombolysis group has higher stroke and re-interventions. There is no difference in 5-year mortality, but thrombolytic group has high recurrent pulmonary embolism admissions. So regarding the acute phase treatment in patients with high-risk pulmonary embolism, it is recommended that anticoagulation with unfractionated heparin, including a weight-adjusted bolus injection, be initiated without delay in patients with high-risk pulmonary embolism. So just establishing the treatment as soon as possible, it is a class 1 indication. Systemic thrombolytic therapy is recommended for high-risk pulmonary embolism, and the surgical pulmonary embolectomy can be used as an alternative in patients who cannot, or in patients who has a contraindication to the thrombolysis. Okay, so for the recommendations for acute phase treatment, intermediate or low risk pulmonary embolism, it's also a class 1 indication to use the risky thrombolytic therapy for patients with hemodynamic deterioration anticoagulation treatment. And however, routine use of primary systemic thrombolysis is not recommended in patients with intermediate or low risk pulmonary embolism. This is a class 3 indication. Okay, so regarding the initiation of the anticoagulation and pulmonary embolism patients, it is recommended without delay, as previously, in patients with high or intermediate clinical probability of pulmonary embolism, even while the diagnostic workup is being done. The anticoagulation is initiated. A low molecular weight or parenterally, low molecular weight heparin or fondaparinux is recommended for over the unfractionated heparin for most patients. When oral anticoagulation is started in a patient with pulmonary embolism who is eligible for a NUAC is recommended in preference to vitamin K antagonist. When patients are treated with vitamin K antagonist overlapping with parenteral anticoagulation is recommended with an INR range between 2 to 3. NUACs are not recommended in patients with severe renal impairment during pregnancy and lactation in patients with antiphospholipid antibody syndrome. This is a class 3 indication. So for using IVC filters, it's not usually common, and routine use of IVC filters is not recommended. Okay, so regarding the early discharge and home treatment, carefully selected patients with low-risk pulmonary embolism should be considered for early discharge and continuation of treatment at home if proper outpatient care and anticoagulation treatment compliance is being provided. So just at the end, the diagnostic strategies. So when we're suspecting a patient with pulmonary embolism with hemodynamic instability, we have to start with a bedside transthoracic echocardiography. If there is no RV dysfunction is being found, then search for other causes or of shock or instability should be started. If RV dysfunction is present, we should proceed with CT pulmonary angio if it is available. If it is not available, then treatment of high-risk pulmonary embolism. When the CT pulmonary angio is available, we proceed with doing the CT pulmonary angio. If it's negative, then we search for other causes of shock or instability. If it's positive, we start with the treatment. So in diagnosing a patient with pulmonary embolism without a hemodynamic instability. So first of all, we would assess the patient clinically, and we will stratify him into a low, intermediate, or intermediate clinical probability or a high probability of having a pulmonary embolism. If he has a low or intermediate likelihood, then we would start with the D-dimer test. If it is negative, if it has negative result, then we would not proceed with any further treatment. If it is turned out to be positive, then we would carry on with the CT pulmonary angio. And if it has any positive findings for embolism, we would start the treatment. If not, then no treatment is provided. So for the high clinical probability or patients of PE, after starting directly with the CT pulmonary angio without doing a D-dimer, if the patient has no PE, then no treatment. If it's confirmed, then we would start. Okay, so and here regarding the treatment algorithm. So as you know, the base is to give the patient anticoagulations. Then would stratify the patient when we're treating them according to the hemodynamic stability. If they are hemodynamically unstable and they are at high risk, then we would start a reperfusion treatment and hemodynamic support. If they are stable, then we would distinguish them into low and intermediate or a high risk. And after having them in low and intermediate risk of PE, we would check for two things. The first thing is the clinical signs of PE severity, and the second thing is the RV dysfunction. So if either one of them is present, we would perform a troponin test. And after having a troponin test, if it was positive, like having a high level of troponin and the presence of RV dysfunction, this is an intermediate high-risk patient. We would start him on monitoring, and we would consider rescue reperfusion if the patient deteriorates. After performing the troponin test, if the troponin was not elevated, the intermediate low-risk patient would be hospitalized. So in case if we don't have neither RV dysfunction nor clinical signs of PE severity or serious comorbidity, so there is no other reason, and patients who has no other reason for hospitalization, who don't have a social support or their families cannot support the treatment, and who do not have an access to the medical care, we would preferably hospitalize them if they have one or more of those factors. If not, then we can do an early discharge and home treatment. So for the chronic treatment and prevention of the PE recurrence. So conclusions from few landmark trials and duration of anticoagulation. So the first one is that all patients with pulmonary embolism should receive 3 months or more of anticoagulation treatment. The second, that after withdrawal of anticoagulant treatment, the risk of recurrence is expected to be similar if anticoagulants are stopped after 3 to 6 months compared with longer treatment period of 1 or 2 years. So also we have the third, extended oral anticoagulant treatment reduces the risk for recurrent VTE by 90%, but this benefit is partially offset by the risk of bleeding. So oral anticoagulants are highly effective in preventing the recurrent VTE during the treatment, but they do not eliminate the risk of subsequent recurrence after discontinuation of the treatment. So for the long-term sequelae of pulmonary embolism, the diagnosis of CTEPH is based on findings obtained after at least 3 months of effective anticoagulation and after the treatment to distinguish this condition from the acute pulmonary embolism. The diagnosis requires a mean pulmonary arterial pressure of more than 25 or more, along with pulmonary arterial wedge pressure of less than 15 or less, documented at right heart catheterization in a patient with mismatched perfusion defects on VQ lung scan. Specific diagnostic signs for CTEPH on CT angiography include ring-like stenosis, Webb's slits, and chronic total occlusion. So here's a simple algorithm for diagnosing the CTEPH. First of all, we have to start with the clinical suspicion. An echo showing a TR of more than 2.8 and more than 3 months of therapeutic anticoagulation. Then we'd start with the VQ scan. If it was negative, then we can rule it out. If it's intermediate, then we are uncertain about our diagnosis. And if it shows like at least 1 to 2 segmental or larger defects, then the diagnosis is more likely. And the two conditions, we would proceed with right heart catheterization and pulmonary angiography. And now for starting the algorithm for treatment. So patient would probably continue on lifelong anticoagulation, and the operability assessment should be started. If the patient can undergo the surgery, then would perform pulmonary endarterectomy. If he is not tolerating the surgery, or if the surgery is contraindicated, we would consider a second opinion by another experienced center. And so there is a targeted medical therapy would either include the referral for lung transplantation or emerging therapies like the ballon pulmonary angiography. Okay, so lastly, for the strategies for follow-up for patients after being treated from pulmonary embolism. So the diagnosis of acute pulmonary embolism has been established. The patient has been receiving the anticoagulation, the follow-up, and then he comes for follow-up at 3 to 6 months. Would check for the presence of dyspnea or any functional limitations. If those are present, then we would head further with doing a transthoracic echocardiography to determine the probability of having pulmonary hypertension. So the patient would be classified into one of 3 categories, either low, intermediate, or high. With low, we would seek alternative causes of dyspnea. Intermediate would consider elevated anti-pro-PNP risk factors for developing CTEPH and abnormal CPET results. For a high considerations, we would do a VQ scan, mismatched perfusion defects. If it was present, then we would refer to an expert to deal with the diagnosis. If the patient has come again to the clinic without dyspnea or functional limitations, we would assess the risk factors for developing the chronic pulmonary hypertension. If no risk factor has been present, then we would focus on the anticoagulation and the prophylaxis along with follow-up with those patients. Thank you.
Thank you, Fatma, for this thorough presentation. So any question or comment for Fatma? I believe we have some time before our presentation with Dr. Becca. So maybe we can start the journal club. We'll have a break until 2:40, and then we'll start with Dr. Nora Gumi.
Sure.
Thank you, Nora. Dr. Noura.
Okay. Just a second. Can you see my screen now? Yes.
We can see your screen, but we
Okay.
cannot see the presentation.
All right.
Yeah, we can see it.
Now? Okay. So can we start?
Yes.
Okay, assalamu alaikum everyone. I'm Noura. Today with my colleague Firas, we'll be debating whether to go for mechanical or bioprosthetic valve and valve replacement. So the proposed scenario is a 50-year-old gentleman presenting as a case of severe aortic stenosis, and what would be the best option for valve type. So my argument will be based on the most recent clinical practice guidelines for management of patients with valvular heart disease. This is the most updated one in 2020 and 20. So first of all, let's just go through some points in this present in this guidelines regarding the valve choice. So number one, in patients with an indication for aortic valve replacement, the choice of prosthetic valve should be based on a shared decision-making process, which accounts for the patient's values, the lifestyle, whether the patient has a contraindication to anticoagulants, whether they're involved in sports, and this is based on clinical expertise and is considered a strong evidence. The second point is that for patients of any age requiring AVR for whom vitamin K antagonist anticoagulation therapy is contraindicated, then it shouldn't be even questionable that they shouldn't go for mechanical because of the strong contraindication. And this is also based on experts' opinions and is considered a strong evidence. For the third point, patients who are less than 50 years of age, and if they don't have any contraindication to anticoagulants, and they require AVR, it is reasonable to choose a mechanical over a bioprosthetic valve. This is based on randomized clinical trials, and it's also considered moderate in strength. Now, for patients who are between 50 to 65, like our scenario here, our patient, who require AVR and who do not have a contraindication to anticoagulation, it is reasonable to individualize the choice of either mechanical or bioprosthetic. Now, let's discuss why mechanical valves are superior. Number one, they have higher durability. So several studies have shown survival advantage with mechanical prosthesis in this age group. Now, some may argue against mechanical because of the increased risk of bleeding associated with lifelong anticoagulant therapy. Now, in general, patients with mechanical valves experience a higher risk of bleeding caused by anticoagulation, whereas individuals who receive bioprosthetic valves will experience a higher rate of reoperation because of structural deterioration of the prosthesis, as well as perhaps a decrease in survival rate. Okay, so my response to that, and also based on the guidelines, anticoagulation with vitamin K antagonists can be accomplished with acceptable risk in most patients who are less than 50 years of age, particularly in compliant patients with appropriate monitoring of INR levels. Now, how can we reduce the risk of bleeding associated with lifelong anticoagulants? Number one, compliance, regular monitoring, in-home testing. We can use the INR meter, patients and family education regarding dietary interaction, the meds interaction, physical activity, and something to consider is support groups. All right, for patients with a mechanical Onyx AVR, and if they don't have any thromboembolic risk factors, we can target a lower INR between 1.5 to 2. In contrast to what we usually do is, if we do AVR replacement, AVR mechanical, we target 2 to 3. But if we're going with Onyx, we can go for less than that. So we're reducing the risk of bleeding. All right, so about the bioprosthetic valves, on the other hand, patients who are less than 50 years of age at the time of AVR incur a higher and earlier risk of bioprosthetic valve deterioration. So number one, why we shouldn't go for bioprosthetic in this patient is structural deterioration observed in biological valves is inevitable, requiring reintervention. In some studies, they claim that newer surgical bioprosthetic valves have less structural deterioration. However, it is associated with high late mortality rate in these studies, which preclude the recognition of valve dysfunction. Now, there is an increased risk of ischemic stroke early after operation, particularly in the first 90 to 180 days after either bioprosthetic or AVR or mitral valve replacement. So even if you go for biological valves, you will still require anticoagulants therapy for a period of time and require monitoring and visiting labs to get INR levels because of the increased risk of thromboembolic events. So to sum up, I think we should go for mechanical valve in this patient because it's associated with high durability, low risk of reoperation. Risk of bleeding can be reduced with compliance, regular monitoring, in-home testing, and patient education regarding the diet, regarding medications that interact. And for bioprosthetic, it still requires anticoagulants, and it is associated with poor durability compared to mechanical valves, with many requiring reoperation in 10 to 20 years or even less than that. Thank you. Yes, Dr. Firas.
Thank you, Nora.
Assalamu alaikum.
Alaikum
So-
salam.
Can you unshare your screen kindly?
Firas, I don't think we have enough time to present now. Maybe after Dr. Becca lecture, you can do your journal club, and then we'll have discussion.
Okay, that's good.
Okay, because we have only 10 minutes. So we'll stop now for 10 minutes until Dr. Becca join us, and then
Sure.
continue the journal club. So just go outside to introduce you, and then you can start. Okay.
Okay. I can unmute here if you want.
Yes. Okay, good afternoon, everyone. Welcome back. So I would like to welcome Dr. Becca to our activity for today. He's going to present about pulmonary thromboendarterectomy. Dr. Becca is currently practicing as lung transplant surgeon, as well as he's a cardiothoracic surgeon. So again, I would like to thank Dr. Becca for accepting our invitation.
Okay, hello everyone. So thank you for your kind presentation and introduction. And yes, I will give a talk concerning chronic thromboembolic pulmonary hypertension and its especially its surgical treatment. So just to start, CTEPH is really different from pulmonary embolism. These, of course, there are risk factors for normal embolism and DVTs and all that kind of things, but really most of the acute PEs are thrombolized very easily and seldom they turn and organize into chronic obstructive lesions. That's very unusual. And the disease is then very different from acute pulmonary embolism. So acute embolism, I have operated very few of those, and the role of surgical therapy is not so clear. Most of them are massive emboli are treated by thrombolysis, and surgery may have a small role there, rescuing some very critical patients though. But the chronic pulmonary embolism, the organizing development happens only in 2 to 4% of these acute cases, and then the story comes very different. So thrombolysis has no role anymore on chronic changes. The chronic changes consists of very strong fibrous tissue, which you cannot remove by thrombolysis anymore. And the surgical therapy is the kind of first choice for treatment for all chronic cases. This is just material 2 years ago from Saudi Pulmonary Hypertension Registry. It's not a national registry, it's a King Faisal Hospital registry. But anyway, we are collecting there mostly patients with group 4 and group 1 diseases. So the most frequent cause for pulmonary hypertension actually is heart conditions because of the left heart disease causing also pulmonary hypertension, but these patients are not concerned of this presentation. The other big group, of course, is it's our resident. Oh, okay, sorry for interruption. So there is pulmonary hypertension also because of secondary causes of lung diseases and especially group 1 also is important, idiopathic pulmonary hypertension, and the treatment in addition to targeted pulmonary hypertension drugs is then lung transplantation at the end stage. But really group 4 here, 31% of our patients, so some years ago 82 patients, that's a group where we are concentrating on now. Shortly about the CTEPH disease itself. So this is a relatively rare disease, and to make the diagnosis, it's not so easy. I think you probably need to have an idea of and suspicion of this disease most often. Otherwise, you don't make the disease at all. And we have seen many patients having very long delays before the diagnosis is made, and even they have visited the psychiatrist or something totally irrelevant before finally getting the right diagnosis. Most often it's misdiagnosed as being COPD or asthma, just explaining the obesity to be the reason for dyspnea. But the thing that half of the patients don't even have a history of an acute pulmonary embolism. So it's a showering of small emboli during the long period of time, makes it very difficult to suspect CTEPH. But anyway, the most common symptom is, of course, dyspnea. May have some pulmonary infarctions causing chest pain. Even the bigger emboli often cause syncope, but that's related of the disease perhaps having acute on top of chronic pulmonary embolism. Pulmonary hypertension is associated with hemoptysis. Of course, at the end, the right heart finally fails, and patients develop right heart failure and ascites and edema of their legs and that kind of thing. So usually it's a long-standing disorder. But the thing in pathogenesis, it's not a clotting disorder. It's a disorder of natural thrombolysis. Because many patients suffer from acute PE, but still very few of those suffer from poor natural thrombolysis, and the reason for that it's unclear. But it's about very small percentage of these acute PE patients, so estimated to be 1 to 4% of patients only. When the patients are diagnosed, they are put on lifelong anticoagulation, but still, if you have already pulmonary hypertension, the disease itself doesn't stabilize. And that's because of the pulmonary hypertension itself is damaging the remaining patent vessels. And these patients, then they develop kind of secondary arteriopathy in the small vessels, which still are facing the elevated pulmonary arterial pressure and also the increased flow in those areas of the lungs which still have the patent vessels. So the prognosis of the patient cannot be solved with anticoagulation only, and even the modern pulmonary hypertensive drugs, they are often used for these patients because of this pulmonary hypertension, but they may help the patient a little bit. They may even improve the clinical status and symptoms, but often the disease still continues worsening, and after a few years, the patient seek help if the surgery can still help them. And often the risk of surgery just becomes higher when waiting for many years before surgery. So this is not the advice of international guidelines to treat these patients with anti-hypertensive medications like sildenafil and Viagra or Bosentan, or there are many drugs for this disease nowadays. Anyway, when suspected, these patients should be examined. Transthoracic echo, if you pay attention to right heart, which may not always happen, gives you the idea that the patient suffers from pulmonary hypertension. So the right heart dilates and gets hypertrophied, and maybe you can even measure the tricuspid gradient and estimate the pulmonary artery systolic pressure. Second study, which is an old-fashioned ventilation perfusion scan. It's not available everywhere, but it's still considered the most sensitive diagnostic imaging method, and it should be used more frequently to exclude the diagnosis. Actually, it should be done for all patients suffering from pulmonary hypertension, since of course CT pulmonary angio is a modern method of doing non-invasive studies, but one still misses some patients, and the technique may not be as good everywhere, and also the experience of radiologists may not be always at the same level, and the peripheral disease is quite easy to miss that. But anyway, in CT images you can see the right heart dilatation and dilatation of bronchial arteries, and then finally the findings in the pulmonary arteries itself. conventional pulmonary angiography has also been kind of old-fashioned study. Radiologists have been reluctant to do this invasive study for the patients, but since few years now, the interest has again been raised because of the option of doing, instead of surgery, of doing pulmonary balloon angioplasties for these patients. And for doing those procedures, one of course needs also very good imaging, and the kind of imaging you do for coronary arteries as well. And the cardiologists have become excited about this possibility too. Fourth study here is the right heart cath, which is of course mandatory to finally to do the measurements and finally to categorize the severity of pulmonary artery hypertension with all the parameters concerning atrium, ventricular, and pulmonary artery pressure and cardiac output, and also to exclude intracardiac shunting and all that kind of things, differential diagnosis. Sometimes the pulmonary artery pressure itself is not very high, and for that reason it's sometimes necessary to do the exercise study and simultaneous right heart catheterization, and sometimes you see the normal pulmonary artery pressure because of the obstruction to go to sky high levels while patient is doing just a little exercise. So that's sometimes very informative study. And actually we have some patients, even operated on patients which only have chronic thromboembolic disease in the lungs. So even the right lung may be totally occluded, but still the pulmonary artery pressure is normal at rest, and we cannot talk about chronic thromboembolic pulmonary hypertension. It's just chronic thromboembolic disease. But these patients may have severe symptoms of mismatch of perfusion and ventilation in the lungs, and they may even be at the limit of being evaluated for lung transplantation because of that. So, and that's of course or also can be an indication for pulmonary endarterectomy as well. And the left heart cath, of course, for elderly patients at least, it's needed anyway. And it may be needed also if you suspect the patient having pulmonary hypertension due to left ventricular failure or left-sided heart disorders. When it comes to the disease itself, the natural history of the disease, this is quite an old material, but if you have mean pulmonary artery pressure 50, the 5-year prognosis is nearly non-existing. Of course, the milder diseases, the prognosis is not so poor, and when you have the pulmonary artery pressure mean value of 20, then the prognosis is near to normal. But anyway, this gives a good idea of why the surgery is indicated for most of the patients, and most of the patients usually diagnosed, they tend to have quite severe pulmonary hypertension. We probably in the future will see more and more of these mild diseases also. And then you, of course, need to discuss with the patient if the surgery really is indicated at what stage. Okay, then starting to talk about the surgery itself. So this is an excellent angiography. It comes from the OR from San Diego. It's just taken with an iPhone, but still you can see the excellent quality of these images. And you can see like the left lower lobe. There's here you see good parenchymal perfusion, but here left lower lobe there's actually not much of perfusion, and also the orifices of segmental arteries, like here especially, you see very nicely how the contrast media is barely able to pass the obstructive lesion in the, and the same thing here in the left right lower lobe. So you know that the patient has disease. I don't know what was his pulmonary artery pressure, but these images are, when they are good, they are extremely valuable for the surgeon. They are not so easy to image, so this needs also experience from the radiologist, and it's not so clear that poor quality conventional angiography gives you anything more compared to CT angio. Okay, but then the procedure we are talking about is pulmonary endarterectomy. And it's kind of a simple procedure. The ideology is simple, to remove all the obstructive lesions, nothing more. But they just really cannot be pulled out. One needs to dissect all the branches as far as possible, as far as there is disease, and you need to identify the disease itself, and you need to do as complete endarterectomy as possible without damaging the relatively fragile pulmonary arteries. So they are not like systemic arteries, which are used and created for facing the high pressure, but the pulmonary arteries are much more fragile. And this is just an example of two specimens harvested from first right lung and left lung, and right lung and left lung. So the outcome in this case, the blue image, was apparently good. They really got out most of these tails going into segmental arteries, and here you got out a big thrombus, but you didn't got out these. Most of the patients do have obstructions in the segmental or subsegmental arteries, and then if you don't remove them, you actually don't help the patient at all. So it's very important to get out as much as possible, and these what we call rat tails. And we do the surgery using median sterentomy. So the disease, it's practically always it's bilateral. If it's not bilateral, most often the pulmonary artery pressures don't go up. So, and actually one doesn't open even the pleura, one only opens the pericardium, and this is an intracardiac procedure. We use heart-lung machine, of course, and cannulate the ascending aorta, which has been cannulated here, and we cannulate both cavas. And like we have seen the next slide, we also vent the left heart from right upper pulmonary vein. And we also vent this pulmonary artery trunk. So to get rid of the most of the blood during the perfusion, even and starting the cooling down of the patient right after starting the perfusion. So we aim to deep hypothermic pulmonary arrest with a temperature of 18 or in between 18 and 20 Celsius. And all the time doing extremely good hemostasis, because these patients, they need lifelong anticoagulation, and we need to resume the anticoagulation quite soon after finishing the surgery, just getting the primary hemostasis, and then you need to go back to effective anticoagulation. So these patients tend to clot if they are not anticoagulated. And this is just showing the access sites for here, the right pulmonary artery, and here to the left pulmonary artery. Just showing it better in the next slides. Okay, here we have cannulated aorta is here, and I cannulate the inferior cava from the appendix of the right atrium, and superior cava goes from here below to superior vena cava, just like stenting in order to elevate the SVC a little bit with how do you call this? You go around and you put a snare around the cava, and then you use that also for lifting the SVC from pulmonary artery. And there is also vent here in the left atrium, and another vent in the pulmonary artery. At this stage, probably perfusion is still going on. We're cooling the patient still, and exposing the right pulmonary artery in between the superior vena cava and aorta, using this cerebellar retractor and doing the dissection. And here we have done the arteriotomy to the right side, and then starting the endarterectomy, and probably this is a little bit poor image, but oh, sorry. This is the orifice of the right upper lobe artery, and starting dissection from there. I will show it in more details soon. The instruments are not very complex, but still they are very important. We are using this kind of long dissector with a rounded tip, and it also has a suction channel, so we can all the time suck the blood which is coming there. And it's very difficult to do endarterectomy while the heart-lung machine is running, because the patient have big collaterals from bronchial arteries, and when there's any pressure in the aorta, the pulmonary arteries are flooded by the blood coming from the aorta through bronchial arteries. So to get excellent exposure, you need to finally stop the heart-lung machine. And you can do that with low temperatures, deep hypothermia. In addition to deep hypothermia, we are using this kind of wrap around the head, in which you have the circulating cold, ice cold water, cooling the brain topically. And when it comes to forceps, we are using this kind of, how do you call them, double action DeBakey forceps, which are resembling and long needle holders, but they are really nice and effective when you are, and they are very long. When you are going to segmental and subsegmental branches, you can really nicely take a grip from the specimen you're harvesting. Okay, this is the cooling jacket around the head. So body temperature before arresting the heart-lung machine is below 20 Celsius degrees. And if we measure the tympanic temperature, it's something 13 or 15 Celsius degrees. So we are really trying to protect the brains, because the arrest times on average I'm using, for example, it's 45 minutes. And that's quite a long time for any brains. And I'm doing this arrest in the 20 minutes periods. So after 20 minutes, I stop the arrest and start reperfusing the patient with this low temperature heart-lung machine. And I will reperfuse 10 minutes. And then I again can go to the next 20 minutes arrest. And really this has proven very safe with these patients. And we haven't practically, if this functions well, we haven't practically seen any more cerebral accidents compared to normal CABG surgery done on bypass. Okay, and then here's one video. Hopefully you can see something. So this is the arteriotomy in the same place as in the image before. This is right pulmonary artery, and the video comes from, so the perfusion is still going on. There's blood, and the assistant is suctioning that, and sometimes you can develop the correct, raise the correct layer just with a dissector, blunt-tipped dissector, but sometimes you need to use a scalpel for that. And this is not me, this is Dr. Madani doing it from San Diego. And he is very experienced surgeon. Obviously, also, it's nice to see that he also has sometimes difficulties in finding the correct layer. And he's spending a lot of time for that, trying not to go through the back wall, and then taking a look at many different layers, and it's the whole intima, and it's part of the media, and this is very important part of the surgery. If you take too superficial layer, you will not get out the disease, and if you go too deep, then the lesion of the pulmonary artery in the peripheral area, it's impossible to repair, and you need to find the correct layer. I have seen a couple of times patients with intrapulmonary hemorrhage at the end of the surgery. And nowadays you may rescue the patient by using veno-arterial ECMO, partially bypassing the pulmonary flow at the end of the surgery, and then you give all the products to induce clotting. And if you have achieved good outcome with your endarterectomy otherwise, and the pulmonary artery pressure is low, then the patient may still have some hope in recovery, and that has happened too. So it's not always a fatal complication, but it often is if you have the significant hemorrhage at the end of the operation. Okay, but so he's going further to the interlobar part of the pulmonary artery, and this is kind of a keyhole surgery. So you really need to go to the peripheral branches, even the lower lobe, and this probably is still the one of the upper lobe ascending branch which he is taking out. And one needs to go and take them separately, one by one. And this is the specimen you should get out, for example, to make the difference in the prognosis of the patient. Sometimes it's very difficult to create and raise the layer in the right or left main pulmonary artery, and you need to go a little bit more peripherally and see the disease itself. And when you see the thickening in the walls of the pulmonary artery, then you can raise separately these layers for segmental or peripheral lesions. This is another example. Just the right side was typical classical proximal disease, and on the left-hand side you only saw the disease in the inferior lobe A7 and A8 branches, and endarterectomy was done separately there. So the classification is 1, 2, 3 actually nowadays. So 1 is proximal, 2 segmental, 3 kind of subsegmental disease, and it's the more and more challenging disease the more distal the disease itself is. The old classification had class 4 disease, and actually this is considered not to be CTEPH at all. So they have done endarterectomy, but really they didn't see any true tapering tails here, and patient had pulmonary hypertension, but they only were only able to endarterectomize the segments which were patent and had a thick wall, but the obstructing disease was not met at all, then the patient did not get any benefit out of the surgery. So nowadays it's considered class 0, not CTEPH at all. So in this case, the disease it's in the small arteries of the of the lungs, probably just inside to thrombosis of the vessels. Okay, and coming to King Faisal Hospital, this is the number of procedures or number of patients seen here in King Faisal hospitals annually. And nowadays, out of these patients, majority has been operated on. This is since 2 years back, this presentation, and or these numbers, and at this time 63% of CTEPH patients were operated on. And you see at the baseline, no, this is not the baseline, this is the whole population. Sorry, whole population of the patients, and about the medication. This is a slide I got. Anyway, still, I would say that nearly two-thirds of the patient after surgery reach the level of normal pulmonary artery pressure. The remaining still have residual pulmonary hypertension, and like it's said here, nearly 40% of patients still have some pulmonary artery hypertension specific or targeted therapy. Most of them had a single drug, and 14% still received combination therapy of 2 or 3 drugs. So the goal was not reached totally, but I guess all of them have had a much milder disease after surgery compared to situation of before the surgery. Sorry. And yeah, this is about the disease severity and functional class. At the baseline, so functional class 1 or 2, 1/3 of the patient, 2/3 were class 3 or 4. And this is the non-operated group, and medication has helped some patients to come to class 1 or 2, but still nearly half of the patients were in class 3 and 4, as compared to endarterectomy group where %. So this is the brown column is for functional class 1 or 2. Okay. And no, I mean, sorry, to explain this, before the surgery, nearly 1/3 of the patients were grouped in 1 or 2, and after the surgery, nearly 90% were functional class 1 to 2. So very small portion of patients after surgery were still in the group of 3 or 4, suffering the disease heavily. And this is just the improvement of 6 minutes walking distance as well. Okay, but to conclude, patients really benefited out of the surgery. We haven't had any mortality, and 2 patients have had some cerebral symptoms, but I guess they will not be permanent. And both clinical and hemodynamic parameters improved significantly. Patients not operated, they show still the disease progression. And the results really favor the practice of surgery. So shortly, okay, this is still for a patient who didn't have pulmonary hypertension. She was a young female patient, still significantly dyspneic, and she had a dream of becoming pregnant, and we agreed on operating on her, and this was the situation when we started the surgery, and mean pulmonary artery pressure still came down significantly. I guess it was 24 when we started the surgery, and it became 18 after finishing the surgery. But sometimes it's necessary for also patients without pulmonary hypertension. And really the outcomes and the survival and the prognosis depends on the pulmonary vascular resistance after surgery. So if you see the vascular resistance below 500 dynes, you can expect the patient long-term prognosis to be excellent. One of the complications is unique one for this surgery. This is called perfusion injury and Steele syndrome, in which you see those areas which were behind the total occlusion before the surgery. Those areas will be mostly perfused after surgery, and sometimes the mismatch of ventilation and perfusion can be so severe that the patient really suffer from hypoxia, and they may need ECMO. And we have had here 3 patients on veno-venous ECMO, so they don't need heart support, but they need ECMO for hypoxia. And we have used this double lumen cannula, which takes blood out from the SVC and IVC, and the oxygenated blood is returned to the level of right atrium. And at the same time, we have extubated these patients because it's very important not to develop further pulmonary complications like pneumonia and that kind of thing. So then things really start to become difficult. But you should be able to wake these patients up and preferably to mobilize them, and by that way to reduce the other chance of other pulmonary complications. So this was a 64 years old female with a severe pulmonary hypertension, and really she would have died without ECMO, which was inserted, I guess, 2 days after the surgery. And she was on ECMO perhaps for 1 week and recovered nicely at the end, and actually has very low pulmonary artery pressures nowadays, and is doing fine. So ECMO sometimes is very good for these patients, but it doesn't help you if you don't get good specimen in the first place in the OR. Okay, this was very tough period for her, but we had excellent team in the cardiac surgical ICU to take care of this patient, and then just shortly, there's competition nowadays, and radiologists and cardiologists are eager to treat these patients with their catheters, and it's of course a nice way of doing things. It's easy for the patients, and you don't need big surgeries, but it's also not without any risk. The rupture of the pulmonary artery while doing the dilatation can be lethal, and but just by learning how things should be done, especially the Japanese groups have had success with this method, and it may be a good addition to the therapeutic choices. Especially there are some lesions like these stenosis, ring-like stenosis, and web lesions shown here. Then it comes more challenging with these subtotal lesions, and one knows that this kind of pouch lesions, then it's becoming dangerous. And also, if you have a tortuosity of the vessels, it's very easy with these wires and balloons to rupture the vessels, and you probably shouldn't go there. Also, when you have big masses in the proximal vessels, if you're not removing them, it's very difficult to imagine that you could benefit out of catheter procedures. But really, for some patients who wouldn't, perhaps for the comorbidities, couldn't undergo surgery, this may be a great option. And also for peripheral disease, segmental and subsegmental disease, this may be finally the first choice of therapy for these patients. And these are kind of examples just showing one vessel being ballooned. Actually, they need to balloon them many times. So I guess most patients undergo 5 to 10 sessions if you want to do complete or near complete procedures. So it takes quite a lot of resources in the cath lab. Of course, the surgery also itself, it's a whole day procedure with cooling down and warming up. And so it's not a small minor thing either. But anyway, in Bad Nauheim I was visiting, and they had a surgeon there who was doing this balloon angioplasty. So it's probably like in heart surgery, you have heart teams, you have surgeons and cardiologists, maybe interventional radiologists taking part in these procedures. It's good to have some understanding about the pulmonary vascular anatomy when you're doing this, and the cardiologists usually don't have. So it needs some dedication also, not just the skills of doing PCIs, and you need to know the risks and the nature of the targets and the anatomical part. Okay, so here we come to the question of operability, which is very unclear. There are no clear guidelines which patients are to be operated and which are not. The recommendation is to operate all patients you only believe that you can operate. Nowadays, the surgery is advised to be done in centers which have experience. The surgeon should have some idea about pulmonary hypertension, of course, the technical expertise, and also the evaluation of the patient, angiographies, and some knowledge about the specific postoperative care. This surgical technique, it can be said to be a little bit difficult to train and to teach and to learn, but when you get the experience and see the procedures done and further train yourself, it's of course possible for anyone having serious interest in the topic. But the important thing is especially to identify the distal segmental and subsegmental disease, and you need to have some experience for that. And of course, the surgery is the main factor in achieving good outcomes. Also, the center itself should be kind of excellent cardiothoracic center. having experience in all fields of cardiac services, especially on pulmonary hypertension. This is multidisciplinary work. We need pulmonologists, cardiologists, and surgeons, and intensivists, and physiotherapists, anesthesists, and all to be working on this. This is the guideline or consensus from the major centers that the surgery should be only done in centers having perhaps 40 or 50 million population which they are serving, and doing no fewer than 50, maybe 100 cases per year. But that's of course if you just want to be ideal. But anyway, the mortality should be below 5% at least, this is kind of what we have achieved here. And I guess the experience has become of cooperating with and collaborating with several big centers, and when one decides to learn things, I think it's worthwhile visiting these centers, doing 3 to 5 cases every week, like in San Diego or Papworth in UK. And this is really nice surgery when you have good outcomes, and this is just to finally
really in the end stage
perhaps have some words from Dr. Jamieson, who was the pioneer in San Diego, making this surgery successful in the first place during the last 30 years. I will stop by here, just listening for your words from him.
Really in the end stage heart failure, very difficult to breathe. We actually make an incision in the wall of the pulmonary artery. So we're making an incision in an artery that's probably the thickness of a piece of paper. And we take out part of the wall of the pulmonary artery. And taking out part of that wall, we also take out this thickened scar-like tissue. And so we get rid of the obstruction. It's now turned into, at least in this institution, a relatively safe procedure. And one of the great things about it is these patients that come in extremely sick go home cured. And probably the only thing to me that's quite like that in medicine is obstetrics, where people come in with a baby, they have a baby and they go home normal.
Okay, and just to conclude that last slide, I think that all of these patients should be evaluated for surgery. They need a lifelong anticoagulation. These new drugs can only be used for patients who are not qualified for surgery, or after surgery they have pulmonary hypertension. And this pulmonary balloon angioplasty, it's becoming real-world procedure. There is some competition even in between surgery and balloon angioplasties, but I still think the surgery, like according to other experts as well, it's still the first choice. But the angioplasty is very valuable means also to treat these patients. Okay, I will stop here, and you can, if you are still there, you can perhaps put some questions or comments.
Yes,
Yeah,
Dr. Bakta, we are still there. I just wanted to say that I like the video so much. I feel that there was a power of teamwork, you know, and when you see your patient walking after weaning them from ECMO and so on, this is the most wonderful moment. Thank you for the great presentation.
Yeah, thank you.
Again, thank you, Dr. Becca, for presenting to us. So if anyone has a question from the audience, probably I can start. In terms of training, Dr. Becca, is there any place around the world for fellowship or a specific training for these kind of patients that a newly graduate cardiac surgeon can practice there?
Well, I think, to my opinion, I have visited several centers in Europe, as well then in San Diego in United States, and I think all the centers are basically mimicking the procedure developed in San Diego, and to me at least, San Diego was without any doubt the number one center. The good thing is that the number of patients, it's huge there. So they do more than 200 cases per year, and of course the experience they have, it's excellent. And also I would say that the attitudes there, they were very friendly. This Professor Jamieson and also Dr. Madani, and the third guy doing, or there are two nowadays. Jamieson has retired. Anyway, they had so nice attitude of towards the visitors and the fellows there. So I would just advise that if there is a chance of visiting and making a long visit or fellowship there, I think that would be most valuable thing to do.
Okay. And in regards to deep hypothermia, I have just a two-parts question. Is there any evidence supporting the use of this head cooling jacket? Because we don't usually use it in cardiac surgery. We just use like regular ice. So is there any evidence supporting this to prevent cerebrovascular incidents? And the other thing, during this prolonged hypothermia, do you use any cerebral perfusion in any of your cases?
So I think the scientific evidence, like the randomized studies concerning these cooling jackets around the head, it's non-existing. I think it's only based on the San Diego experience. It's used also in Papworth, being nowadays as big center as San Diego. I think it's at least theoretically described that the cold effect of the cold environment, it's more evenly divided into all regions, also the back side of the skull compared to ice. And when they are using it, it's very standard technique, and they have been happy with this. And San Diego is just reporting, like because of the huge number of patients, I think more than 1,000 patients, sequential patients, having no central central nervous system damages. So the outcomes are so good that's why I prefer to do. I don't think in Europe the ischemia times are a little bit shorter than in San Diego. So like in cardiac surgery, most of the surgeons are trying to avoid deep hypothermic circulatory arrest, but this way of doing it, like they do it in San Diego, it seems to be very safe, and that's why they are using, and that's why I'm kind of following their experience. We also give thiopental or steroids or maybe some other drugs, but I still think it's this cold which is saving the brain tissue, and that's the most important thing. And limiting the arrest periods to 20 minutes and 10 minutes reperfusion. In Italy, I think they do only 7 minutes arrests and reperfusion, and then continuing with 7 minutes again. But that's a little bit too short time of doing things.
Thank you. Do you prefer any type of anticoagulation, or like new generations, or just warfarin, or is there any difference between?
Yeah, we have been we have been a little bit conservative, but warfarin is I think still the first choice for patients having antiphospholipid syndrome, which happens to be very frequent here in Saudi Arabia. And also in perioperative period, I don't like these new anticoagulants which you cannot reverse. So we bridge the patients with enoxaparin, usually 5 days. Stop if the patient is on new oral anticoagulants. We stop them 5 days prior to the surgery. We bridge them on therapeutic dose of enoxaparin, and we stop that 1 day before the surgery. So there is 36 hours without any anticoagulation, and then they go to OR, and we start the anticoagulation at the night of after surgery. So 6 hours after closing the patient, we again start enoxaparin or heparin. And
Okay.
And after the discharge, some patients get these new oral anticoagulants, but the time before taking out the pacemaker wires and that kind of things, I don't want to have these new agents there.
Thank you. So any other question or comment from the audience? Dr. Farid, do you have any comment from your side? Dr. Farid is a program director in King Faisal.
Very nice presentation. Thank you very much, Dr. Becker. I think this is very detailed, and each resident should review those presentations. You may need it sometime. I agree with you that San Diego may be one of the best places. I did visit that place a long time ago, and I met Dr. Madani, and he's very receptive. And any of you who's interested of doing a fellowship, I can contact him personally. Thank you.
Yeah, you're most welcome. I totally agree with you with experience of San Diego.
All right, thank you very much again, Dr. Becker, for joining us today. So we'll have another 10 minutes break, and then we'll resume our general club. Thank you.
Okay, thank you so much.
Thank you.
Okay, thank you very much. So you're continuing the session. I stopped sharing. Yeah.
اوكي بعدين نروح نبحث ثاني ما في ملازم. ملازم حق فصل خليكم صوت
فراس.
Yeah.
Yes, you can start.
طيب السلام عليكم. So Firas Fatani, cardiac surgery surgeon from King Abdulaziz University Hospital in Jeddah. So I'll be supporting the bioprosthetic valve in this debate. So the content will be, I'll review the current guidelines in the beginning. Mainly I'll discuss it fast since Dr. Noura did discuss it. Then I'll present some journals or some articles that support my opinion in choosing my prosthetic valve in patient who's 50 years of age. So to summarize the current guidelines, it is class 1 that the decision for prosthetic valve to be shared decision between the physician and the patient. And if the patient has contraindication or cannot be managed or do not desire vitamin K agonist anticoagulation, bioprosthetic valve is recommended. The first study I'll be discussing is this study done in between 2002 and 2008, which the title of Quality of Life and Anxiety in Younger Patients After Biological versus Mechanical Aortic Valve Replacement. So this study was conducted in Munich, German Heart Center between 2002 and 2008. The population size was 122 with a response rate of 86. The study was cross-sectional. The population of the participant were grouped in two groups. First, who received mechanical valve, they were 46, and those who received bioprosthetic valve, and they were 59. So they received 3 questionnaires that assessed quality of life and anxiety. The first of which was SF36, which is a questionnaire that measures mental and physical quality of life. This questionnaire showed no significant difference in the sum and sub scales. The second questionnaire was fear of progression in chronically ill patient that assesses anxiety in chronically ill patient. The second questionnaire showed significant difference in the sum and sub scores with a p-value of 0.038, and the third questionnaire was cardiac surgery anxiety questionnaire, and it didn't show significant difference, but there was tendency in some domains of the questionnaire favorable for biological valve. So this is from the second questionnaire, fear of progression, and it shows that the questionnaire had 3 main domains: partnership, sexuality, and family. The sum p-value had a significant score of 0.03, like I discussed before. There was clinical significance in the sub-scale of partnership, mainly in the thought that they might lose their partner, 0.03. Also, there is in the subcategory of sexuality, fear that sometime in the future they will no longer be sexually attracted, and there was clinical there was a significant p-value. Also, in the family, there was no significant, but there was a tendency that the patient or who had mechanical valve believe that they should not burden their families and fear about their future. The last questionnaire, which I discussed, the cardiac anxiety, did not show significance, but it showed tendency in the two categories of avoidance and attention. Avoidance of certain activities due to anticoagulation, and the attention to the heart sound produced by mechanical valve. There was also valve-specific questionnaire distributed to patients who had mechanical valve, and it showed that 85% had disturbance from the mechanical heart sound, and 40% restriction of anticoagulation. So they had restriction in their daily activity. There is also an old study that the title of which is Problems Associated with Mechanical Heart Valve Sounds. And it showed sleep disturbance in 52% of the patient and 46% in the patient's partner. And there was 36% interference in the concentration and 28 social embarrassment. The second study I'll be discussing is association between satisfaction with and adherence to warfarin therapy on the control of international normalized ratio, a hospital-based study in Saudi Arabia. So this study was conducted in 2016. The study was lasted 3 months, and it was conducted in anticoagulation clinic in the cardiac center in King Fahd Hospital in Qasim. The inclusion criteria was any patient who received anticoagulation with warfarin for 6 months or more, or and who were 18 years old or older. The population size was 300. The result of which showed that slightly more than 30% of the interviewed patients were classified as adherent to treatment, and this is very low. Also, 45% of patients achieved the target INR range, and this is also very low. The target INR is said to be achieved if the time to treat time in targeted INR range, if time in the therapeutic range if more than 75%. So there was a similar result in other studies done in the region, mainly in Qatar and Sudan. But yeah. The other studies I want to discuss is the failed or stopped alternative to warfarin, mainly the Realign trial and CAPTA trial, where they both tried the use of alternatives to warfarin, dabigatran in the Realign trial and dual antiplatelet in CAPTA trial. So they stopped prematurely, mainly due to increased in cardiac events or events in the patients. There is also the effect of home testing of international normalized ratio on clinical events, and it showed no reduced risk of stroke or major bleeding episode and death among patients taking warfarin. Lastly, I'll talk about this article that was based upon the clinical the recommendation done by the American Heart Association was information from which the guidelines were taken. So this study was conducted in Vancouver in Canada, and it was a micro simulation of 3,934 patients with primary aortic valve replacement. The total life expectancy was not different in both groups, and the overall observed mortality of bleeding in the case of mechanical valve was 22%, and this is very high, and to some extent the mortality from bleeding most commonly comes in a catastrophic situations. The reoperative mortality was 7%. So this graph shows the lifetime risk of reoperation or bleeding. So by the time the dotted line shows the bioprosthetic valve, the bleeding risk with bioprosthetic valve, and the continuous line shows the bleeding risk in bleeding. Yes, the continuous line shows the bleeding risk in mechanical prosthetic valve. Here also shows lifetime risk of reoperation if the patient was in mechanical, the black bar, and the gray one, risk of reoperation if the patient received bioprosthetic. So this diagram shows the life expectancy, and there is a similar life expectancy in both groups. So based upon those studies, the increased quality of life in patients received bioprosthetic valve and the adherence to vitamin K antagonist in Saudi population, I lean toward bioprosthetic valve in this case. So thank you. If you have any questions or comments, feel free.
Thank you, Firas. So, Noura, are you convinced with what Firas presented?
I want to respond to some points that he mentioned. Hello, can you hear me?
Yes.
Can you hear me?
Yes.
Okay. So the first point, he mentioned anxiety. Now, this is pretty much normal after any surgery, specifically cardiac surgeries. I don't think it's mostly associated with mechanical, and even the evidence he presented did not show significant difference between biological and mechanical valves in terms of anxiety. And it was also based on general questionnaires. I mean, depends on people's moods and how their general well-being when they're filling these questionnaire. So I don't think it's 100% accurate. And then he mentioned the attention to the mechanical valve sound and the disturbance because of it. I think this could be true at the beginning, but then patients will eventually get used to the valve sound and to the anticoagulants and their routine. So these things could be a problem at the beginning, but they should get used to it. And he mentioned warfarin adherence. So he didn't mention the patient's background, their socioeconomic status, their ages. This could it depends on the patient themselves, where they're living, if they have available centers to get INR checked. And he mentioned also about the INR meter. It's a convenient way. It's fast. Uses finger prick and stick instead of collecting blood samples and sending them to labs. So it's actually the INR meter is convenient. I think it's a good way to monitor, and it will help patients as well. Yeah, that's it. One point about the risk of bleeding. That's why during my argument, there were specific things to do to reduce the risk of bleeding, including compliance, monitoring, and also patient education. We can avoid the risk of massive bleeding that can increase the mortality, to avoid dietary interactions like green vegetables. We can inform them about the medications that could interact with anticoagulants and increase their effect, lead to bleeding. Could be like the simple common ones like NSAIDs, SSRIs, some antibiotics. Also about the physical activity, they can replace, if they're into contact sports, they can replace them with other sports, not necessarily become sedentary, but to replace the sports. Avoid soccer, for example, American football. Yeah, that's it.
Firas, any reply from your side?
Yes, of course. Firstly, in case of the first comment you mentioned, the quality of life and anxiety. So I use the cross-sectional data for that showed significance in certain questionnaire that is used and to assess anxiety. So how do you want to assess anxiety other than do you have other things to assess anxiety? Second of all, the INR, the study I presented, there is no other studies that shows I presented evidence. I presented studies that prove my point of view, and there is no in our region. There is no other than the study that I can present.
Okay, I think mental illnesses in general are very common, and your study didn't mention whether your patients had mental issues prior to the operation. Like they could have family history, predisposing factors, and on top of that, they underwent open heart surgery and they developed this anxiety. So there's no way we can accurately say this happened because of mechanical valves. It's multi.
But at least I used some evidence, and the group were categorized into the the population was divided to two categories, those who received mechanical and those who received bioprosthetic. So it compared those two groups. So there is evidence, and to some extent. At least I presented some evidence.
Okay, anyone from the audience leaning toward one side has any comment or? So from my personal opinion, that I'm leaning towards the prosthetic valves, because we have, as Firas mentioned, we have a major issue with lack of compliance with anticoagulation, especially in our country, and we see it on a daily basis in our clinic.
What do you mean by prosthetic valves?
Biological valve, sorry, bioprosthetic. So, with the advances in the technology of this bioprosthetic valves, and also the ability to do maybe TAVI, valve in valve, after if this valve degenerate. So that's why I may lean toward biological valve more than mechanical. But after all, it should be counseled with the patient himself, and pros and cons of each one should be explained clearly.
I agree with you. We sometimes forget about those things. You have to talk to the patient. Yes, you have to consider age. You have to consider if, for example, a female is gonna get pregnant or something. You have to consider many things, but sometimes you forget to just talk to the patient. And yes, Nora, some of them, they will be annoyed with this sound of the valve. Yes, you are right. Maybe sometimes some of them, they will get used to it, but it's really annoying. And as I mentioned, we have the issue of compliance, and we see this a lot in the clinic, really.
Okay, can I say something? I think in our society we have lack of education to the general population. It's not just like anticoagulants. Patients have really huge issues just taking insulin or taking antihypertensive. So it's not specific. Like, I think the issue is we need more patient education rather than changing the entire approach to the treatment.
You're not gonna change it, but this is what I mean. This is I agree with you 100%. We need to talk to the patient. We need to educate them. It's not only about the case. You have to talk to the patient. He or she is a human at the end. Yes, I agree with you.
So mainly it is agreed upon that the population between age of 50 and 65 should be discussed and individualized according to the patient. But here in our society, as we mentioned, there is a decrease in adherence and compliance mainly. So this might change the outcome of survival if the trials were done here in this country. If the adherence increased, that would be a different story.
I agree with you.
I think, again, we're generalizing. Not everyone, like the adherence problem, yes, it exists, but we can't say the entire society have the same issue. It depends on the patient's education and background and socioeconomic status and all of that. So it is worth talking to the patient and explaining everything and individualizing the decision.
A question, please. So Noura and Faraz, what is the adherence and within range results for INR in Holland, for example?
So from the study, I've read that adherence, if the patient has high adherence, the INR result or the time in the therapeutic range would be 3 times or 3 times higher than those who are not adherent. Adherence mainly involve patient having knowledge about his medication, the risk of bleeding, how to test for reaching targeted INR, and so forth.
But this was the study in King Fahd and Al Qasim's, right?
The study in King Fahd was showed that adherence is very low, but the study in Munich, not in Munich, in Qasim, yes, this study was conducted in Qasim, but there was similar study. I guess you mentioned the one in Holland.
The one in Maastricht in Holland shows exactly the same results, and I'm taking that away from you, Noura, because even at highly educated society, even with better adherence, people are still subject to variation, mainly because what they eat and how they behave during the day. So the people who are out of range is almost 50 to 60% in even the best, what we would label as highly educated societies. It's still an issue. So you have to take that in consideration. And I must say, I enjoyed the presentation, both presentations. I like, it's more convincing to listen to Faraz though. Maybe because the evidence he's using is like visual, multiple studies with different backgrounds here and there, and the way he presented it. But the choice of those valves still always a question at certain groups. Younger population, pregnancy wishes tend to make you think of more biological valve. I digged into the knowledge of biological valve for quite some time, and I see the evidence definitely improving over the years because of the manufacturing and attention to the calcifications that happens to those valves. So the preparation, the fixation, the pressure used, and the type of tissue that is used, the alignment of the collagen fibers in that tissue. And on top of all that, what's coming up is even more surprising, like the stem cells impregnated skeletal kind of tissue. So they would use that to prepare it from the patient's own tissue, and that's expected to last for a long time. Of course, with the new chances of valve-in-valve, that make it more attractive. But how long was that study, Faraz, the one that you presented related to the showing that there's no difference between the two? How long did they follow the patients? Because I see some of them are up to 75 in the graft.
So the study was conducted. I can show you the study on 1 second. I think it was like 20 years or so. Let me.
Of 20 years?
1 second.
Or they listed all the patients. I see that in the graph, but I don't know exactly how long did they follow each group of patients. In general, for everybody else, the current contemporary experience says that beyond the age of 70, you would use tissue valves. Nowadays, we are thinking more and more of tissue valve in younger ages, like the young 60, for example. But mechanical valve still is considerable portion of patients who get mechanical valve. I'm not sure of the exact number, but I thought it's 1/3, 2/3 distribution.
So this is the study, I guess. I can't find it, but
you probably find it in the methods of the patients that used patients selection. But anyway, yeah, I think it's too much time. I'll leave the floor for other questions and other comments from colleagues.
so here is the mean of follow-up was 6 years in the bioprosthetic valve and 8
So
years
that's
in
a very
mechanical.
short. That's a very short period for follow-up, and that can be taken against that study. The reason I'm saying that we rarely see nowadays degeneration of valves in that period, and the current literature says that those valves may last to up to 15 to 20 years without degeneration. Anyway, so maybe if you're having a life expectancy within that period, maybe 5 to 10 years, you should think. And that's why I think the wisdom comes of selecting those patients who are 70 and older.
Okay, anyone else have comment? Abdullah? Adib?
Yes, Lord.
Still convinced about mechanical change?
Well, it's difficult to decide. I believe mechanical valve, like another way to look at it, and regardless of my personal judgment or personal opinion about it in general, but to look at it from one perspective, that is the well, you pointed out the valve-in-valve risk of stroke. Sorry, valve-in-valve option is available. Now I can look at it from another perspective. So you're if a patient will, how a patient would look at it from this perspective, he would be having a nearly definite another intervention, whether it's catheter-based or surgical-based. A catheter-based intervention itself will have also its own risk of stroke. So he will be subjected to this kind of stroke, this kind of risk twice at his life, minimal, yani twice, and so this is a one way to look at it. The other side would be sub-therapeutic INR in the. So if a patient would look at it from a risk of stroke, like sub-therapeutic risk of being sub-therapeutic anticoagulation, on the other hand, having a 2 interventions with its own risks of many things, including stroke. So I would still lean towards mechanical valve in certain populations. But I believe at the end, it's patient to patient call. And I just wanted to point out that having the option of valve-in-valve is not as easy and not as bright and not as people might think. It has its own risk of stroke and those kind of things. Yeah, that's it.
Okay, Abdul Badi', are you there?
Haytham and Hussein, I'm not sure if they are here from the previous batch because they have good experience with reading articles.
Haytham apologized for joining today. Zainab, Muhammad, Jalal, do you have any opinion?
Hi, I was actually going to comment. I think overall, at least in our experience so far in our training, you see quite a wide variety of patients, and as multiple people mentioned, you have to tailor your decision to the patient who you're going to do your valve replacement for. So we've had patients who come from places where they don't have easy access to healthcare. So if they have any issues, if they run out of their warfarin, you don't know if they're going to be able to get that refill in time. So for those patients, I think you can explain the risks and benefits of each option to them. But at the end of the day, if you know very well that compliance is going to be an issue, I think you also have a responsibility to advise them on what you think is best as well. The other point maybe that I wanted to, or that I was thinking about looking at the rates of compliance and people or patients being in the therapeutic range is how that translates to actual thrombotic events. We've had a lot of our colleagues who trained in Egypt, they noted a significantly larger number of people coming with thrombosed valves over there compared to here. And obviously access to healthcare is a significantly bigger issue over there. So I'm curious how, or maybe that's a good idea for another study in the future, is to compare different areas and the rates of therapeutic anticoagulation and the actual recorded rates of thrombotic events. And that's all.
Thank you, Muhammad. Okay, any other comment from the audience? All right, so I believe we'll end our session for today. It was a very fruitful session, and by this session we'll be stopping our activity up until after Al-Fitr Eid. So Ramadan Kareem to all of you. And,
First, congratulations on this journal review. I think it was very nice to resume that. And it's very unfortunate that you're going to cut off this activity during Ramadan. Do your patients take vacation also in Ramadan?
They usually postpone their surgeries, but so maybe just to refresh and meet after Eid, inshallah. So thank you all for joining today, and see you.
Thank you, Bolo. I thank you, everyone.